Hi, good afternoon. Welcome to this session of pharmacology. Please confirm whether my voice and video is clear or not for you people. Good evening. Good evening, Manoj Bishnoi. I'm just able to connect with you on chat. Yes, so please confirm me whether I'm audible or not. Fine. So thanks for the confirmation, Dr. Trilok Keswani. So let's start with this pharmacology session. Let's start with pharmacology section. So the first topic, so 25 MCQs, which are mostly clinical for you people. The first topic is ANS, and in this topic of ANS, you can expect to have 2 or 3 MCQs in your exam, right? So last year there was a question on organophosphate poisoning. Right, so in last year they have asked about organophosphate poisoning management and everything. So this year, because they have already asked about OP poisoning, I suggest you that OP poisoning you should not consider for this year exam, because mostly they do not repeat the questions, right? So instead of keeping OP poisoning as a first option, which is a very important topic in autonomic nervous system, my suggestion is to read anti-glaucoma drug this time, because in last 1 or 2 years the number of questions are less from this topic. So the most important topic for your this year exam, according to me, is autonomic nervous system. In autonomic nervous system is anti-glaucoma drugs, right? So anti-glaucoma drug is the most important topic for you people. And question number 1 is based on an anti-glaucoma drug side effect. So anyone would like to answer? A 29-year-old female, she is suffering from open angle glaucoma and she was put on some anti-glaucoma drug. Now she is taking this medicine continuously, and after 9 months of therapy, she is presented with abnormal growth of eyelashes. So this is the first thing. So she is presented with abnormal growth of eyelashes, as well as she has some changes which are given in this image. So if you can find out, there is a change in the color of this iris. So if you look at here, there is a change in the color of this iris, and this is a brown discoloration of iris. So this is a brown discoloration of iris. So her iris color is normal, iris color is blue in this case, but she has got some brown patch in between. So now the color is irregular, asymmetrical. We call it heterochromia. So we call it heterochromia iridis. So heterochromia means the different colors, mixture of colors, and it's a problem of iris, so we call it heterochromia iridis. So there are 2 side effects which are given in this question. The first is, medicine has caused abnormal growth of eyelashes, number 1. Number 2, there is heterochromia iridis, that is a different color of iris. The side effect of prostaglandin analog, the answer is B, Bombay. So most of you have given the correct answer. So I can read the names of many doctors from here: Dr. Sagar, Dr. Khyati, Sujit, Manoj, Arnab, Dilip, Fayaz, Umang, Sean Mani. All you have given the correct answer. The answer is B, Bombay. The side effect of prostaglandin analogs. So please remember, prostaglandin analogs which are given for the treatment of glaucoma are PGF2 alpha analogs. So these medicines are mainly PGF2 alpha analogs, and these medicines are considered as drug of choice for the treatment of glaucoma. So prostaglandin analogs are the best medicines for the treatment of glaucoma. So if we talk about these anti-glaucoma drugs, so if we talk about these medicines which are anti-glaucoma drugs, so we can divide these medicines in 2 groups. The first group of medicines are those which can increase the drainage of aqueous humor. The second group of medicine is medicines which can reduce the synthesis of aqueous humor. So medicines which can increase the drainage of aqueous humor, or the medicines which can reduce the synthesis of aqueous humor. So if we talk about drainage of aqueous humor, there are 2 types of drainage of aqueous humor. The first is known as The first type of drainage is known as trabecular outflow. So first type of drainage is known as trabecular outflow. The second type is known as uveoscleral outflow. So first is known as trabecular outflow. The second is known as uveoscleral outflow. So the medicine that will increase trabecular outflow, the drug name is pilocarpine. So medicine is pilocarpine, and the medicines which will increase uveoscleral outflow are prostaglandin analogs. So prostaglandin analogs are the drug of choice, overall best medicines for the treatment of glaucoma. Right, these are the best medicines which can act by increasing the uveoscleral outflow. We have some medicines which can reduce the aqueous humor synthesis, and these medicines are like beta blockers. So these medicines can be beta blockers. Medicines can be alpha 2 agonists. So medicines can be beta blockers, alpha 2 agonist, which can reduce synthesis of aqueous humor. Number 3 group of medicine can be carbonic anhydrase inhibitors, and number 4 is your mannitol. So mannitol is the one that is always given by IV route. Mannitol is the one that is always given by IV route. Now this question is based on side effects of anti-glaucoma drug. So if we talk about side effects of pilocarpine, so during our class discussion, we discussed that there are 4 side effects caused by pilocarpine, and you can remember these side effects by this mnemonic of P. Now anyone who is here and would like to answer, what are the side effects of pilocarpine? What are the side effects of pilocarpine? Anyone would like to answer? So pilocarpine is a drug which can cause pinpoint pupil. So this medicine will cause pinpoint pupil, and because of this pinpoint pupil, patient vision remain deteriorated. Number 2, this medicine can also cause pain in eyes. Number 3, this medicine can also cause blockage of punctum. So this medicine can also block the punctum, that is nasolacrimal duct. And number 4 side effect of this pilocarpine is this medicine can also cause peripheral retinal detachment. So there are 4 important side effects of pilocarpine which starts from alphabet P. One is peripheral retinal detachment, second is punctum blockage, third is pain in eyes, the fourth is pinpoint pupil that will deteriorate the patient vision. Now if we talk about the side effects of prostaglandin analogs. So if we talk about side effects of prostaglandin analogs, so please remember a mnemonic, that is, so the mnemonic is CLIP. So these medicines can cause a side effect, we call it CLIP. So these medicines will cause a side effect like cystoid macular edema. So medicine will cause cystoid macular edema. Medicines will cause increased length of eyelashes. So these medicines can increase the length of eyelashes. So L stands for increased length of eyelashes. So cystoid macular edema, increased length of eyelashes. These medicines can cause inflammatory reactions in eyes. So medicines can cause inflammatory reactions in eyes, for example, uveitis. So medicines can result in changes like uveitis, keratitis. So inflammatory changes because these are the prostaglandins, and these medicines will also cause pigmentation. So particularly these medicines will cause iris pigmentation. We call it heterochromia iridis. So this is the side effects of prostaglandin analogs. If we talk about side effects of beta blockers, these side effects are mostly seen with timolol. So there is a drug which is mostly associated with side effect. The drug is timolol. So this medicine can cause side effects like mnemonic is ABCD. So these medicines can cause allergic reactions. These medicines can cause burning sensations, can result in burning sensation, can reduce the corneal sensitivity. So medicine can reduce the sensitivity of cornea. These medicines can also cause dryness of eyes. So drug will cause dryness of eyes, and please remember one more side effect, that is superficial punctate keratitis. Now apart from that, this timolol is a drug. This medicine should not be given to a patient of asthma because this medicine by systemic absorption can result in bronchoconstriction. So medicine can also result in bronchoconstriction. That's why this medicine is avoided in patients of bronchial asthma. After that, we have medicines which are known as alpha 2 agonist. So in alpha 2 agonist, the drug name is brimonidine. So brimonidine reduces aqueous humor synthesis, and this brimonidine can cause a side effect. We call it lid retraction. So this will cause a side effect of retraction of eyelid, and this medicine should not be given to a neonate. Medicine should not be given to neonates and children, otherwise there is a risk of respiratory suppression. There is a risk of respiratory suppression. So medicine is alpha 2 agonist. So these are the some important side effects of anti-glaucoma drugs, right? So question number 1 is based on side effects of prostaglandin analogs. So side effects of anti-glaucoma drug, question number 1, answer is bimetoprost, right? Any doubt if you people have, please ask me. Doctor, your question is which topics are important in pharmacology for last 20 days? Doctor, whatever topics we are going to discuss today, I will teach you 42 topics of pharmacology. So my suggestion is to read these 42 topics. That will solve approximately 60% of your MCQs in pharmacology, right? Or we have a revision session. We took revision session few days back in our regular batches. So I suggest you to watch that video of revision session. So that will solve your 80 to 90% of MCQs, right? Now question number 2. Anyone would like to answer? What is the answer of question number 2? A 60-year-old cigarette smoker. So patient is a cigarette smoker and also suffering from COPD. So patient is a cigarette smoker suffering from COPD, and because it's an old person, that person is also having BPH, benign prostate hyperplasia. Now this patient has come to you with breathing difficulty. Patient has come to you with breathing difficulty and you want to start a bronchodilator, right? So you have started one bronchodilator, and when you have started this bronchodilator, as a result of this bronchodilator therapy, patient BPH symptoms of urinary retention has enhanced. So there is an exaggeration of urinary retention by using of these bronchodilators. So patient is having COPD, first problem. Patient is also having BPH, right? So for the treatment of COPD, because right now the patient has come to you with the current problem of breathing difficulty, right? So you have started a bronchodilator, but as a result of this use of this bronchodilator, patient has the exaggeration of BPH symptom, that is retention of urine. Now which of the following drug is responsible for this? Now purpose of putting this question number 2 is, first topic which is important for this year exam is anti-glaucoma drug. The second topic is, this topic is very frequently asked in exams. So last year they didn't ask this topic, so that's why there is a probability that they will ask this topic this year. So this topic is based on contraindications of anticholinergic drugs. So in this case, the best answer is tiotropium bromide. So tiotropium is a drug. This medicine is given by inhalational route. This medicine is an anticholinergic drug. So this medicine is an anticholinergic drug. This drug is an anticholinergic drug. We call it long-acting muscarinic antagonist. This medicine is long-acting muscarinic antagonist. It's a long-acting muscarinic antagonist drug. The drug name is tiotropium. There is one short-acting also. The name is ipratropium. So short-acting is ipratropium. The long-acting is tiotropium bromide. So these medicines are contraindicated. The anticholinergic drugs. Anticholinergic drugs are contraindicated in two conditions mainly. Number one, if a patient is suffering from retention of urine. So if a patient is suffering from retention of urine like BPH in this case, or anticholinergic drugs can cause mydriasis. Anticholinergic drugs can cause mydriasis, and as a result of mydriasis, these medicines can close the angle in the eye. So close the peripheral angle of the eye. So if the patient is suffering from closed angle glaucoma, if the patient is a case of closed angle glaucoma, these anticholinergics are contraindicated. So there are two contraindications where anticholinergics are better not to be started, or they are avoided, or they are contraindicated. First is patient is suffering from a disease where patient is having symptoms of urinary retention, or second is if patient is suffering from glaucoma, these medicines will cause mydriasis and can close the peripheral angle. So answer to this question, the best answer to this question is tiotropium bromide, right? Now regarding this question, please remember, if we talk about cholinergic drugs, action in the body, there is a mnemonic for this. The answer is dumbbell. So during our class discussion, we have discussed the actions of cholinergic drugs. So cholinergic drugs you can remember by this mnemonic, dumbbells. So if we talk about anticholinergic drugs, if the question is placed on anticholinergic drugs, so anticholinergic drugs will do the action which is opposite of these dumbbells. So anticholinergic drugs will do the action which is opposite of these dumbbells. Now this is a exercise for you people. You have to tell me what are the actions of anticholinergic drugs. You have to just think about the full form of cholinergic actions in the body, and after thinking about this full form of cholinergic drugs in the body, just tell me what can be the actions of anticholinergic drugs in the body. So I'm waiting in the chat box. So Dr. Faizan, we are talking about parasympatholytic action, not the parasympathomimetic action. So parasympathetic action is dumbbell. Opposite of parasympathetic is anticholinergic action. So what can be the opposite of dumbbells? Anyone would like to answer? Very good. So Dr. Ritvik. So Dr. Ritvik Rajput, you have given the answer. So D stands for diarrhea. So these medicines will cause opposite of that, that is constipation. U stands for urination. U stands for urination. These medicines will cause urinary retention. So instead of urination, medicines will cause urinary retention. M stands for meiosis. These medicines will cause mydriasis. So these drugs will cause mydriasis. B stands for bradycardia. These medicines will cause tachycardia. So these medicines can result in tachycardia. B stands for bronchoconstriction. These medicines will cause bronchodilation. In this mnemonic, L stands for lacrimation. These medicines will cause dry eyes. S stands for salivation. These medicines will cause dry mouth. And S also stands for sweating. So these medicines can reduce the sweating. So all these are actions of anticholinergic drugs. So these medicines can cause constipation, retention of urine, mydriasis, tachycardia, bronchodilation, dry eyes, dry mouth, and sweating. So please remember the actions of anticholinergic drug. The classical example of anticholinergic drug is atropine. So all these are actions of anticholinergic drug. The classical drug of this group is atropine. But there are two conditions where medicines are strictly contraindicated. One is a case of glaucoma. The second is a case of retention of urine. So most of you have given the correct answer. Dr. Faizan, now the answers are correct. Dr. Rishi, correct answer. Sultan, good. So most of you have given the correct answer. Dr. Imran, you have also given the correct answer. So that is all about question number 2. So let's move on to question number 3. Okay. So if we talk about this topic, autonomic nervous system, so I suggest that you should read anti-glaucoma drug for this year exam. Second is you can read about the side effects of anticholinergic drugs. So you can read about the side effects of anticholinergic drugs. The third, the question which was asked in the last year exam, that is OP poisoning. So please read about OP poisoning also, because the question can be repeated this year. So OP poisoning is a cholinergic poisoning. The antidote of choice for OP poisoning is atropine. So read about OP poisoning also. Now let's move on to the third question. So third question is taken from respiratory system. So after autonomic system, we are moving on to respiratory system. So patient is suffering from bronchial asthma, and we know that for bronchial asthma, drug of choice is inhalational corticosteroids. Best medicines for bronchial asthma patient is inhalational corticosteroids. So this patient was put on inhalational steroids, but along with steroids, to improve its efficacy, we have given long-acting beta-2 agonist, right? So when you started this combination in this patient, all can be seen as an adverse profile of steroid use except. So you have to find out whenever you give steroids by inhalational route. Whenever you give steroids by inhalational route, we call them inhalational corticosteroid. So which side effects can occur? So this question is based on side effects of steroids. Why I am putting this question? Because in last 1 or 2 years, they have asked about the side effects of beta-2 agonist. So LABA drug side effects, they have already asked in last few years exam. So this year they might ask the side effects of inhalational steroids. So just to avoid the misfiring of the question, I suggest you to read the side effects of steroids, inhalational steroids, right? So please remember, whenever we give inhalational corticosteroids, okay fine, let me check your answers first. So some of you are answered about A, C, D. Okay. So far only one student has given the correct answer. That is Dr. Reena Chaudhary. So Dr. Reena Chaudhary, very good. Dr. Reena Chaudhary has given the correct answer so far. So please remember, inhalational corticosteroids will not cause bronchiectasis. Inhalational corticosteroids will not cause bronchiectasis as a side effect. Please remember this. So if we talk about side effects of inhalational corticosteroids, please remember there are some side effects which are known as local side effects. So the most common local side effect of steroid is oral thrush or oral candidiasis. Other side effects are these steroids can also cause the change in the voice. So patient voice will be changed. These are the local side effects. But we discussed also during our lecture that whenever we give steroids by inhalational route, you have to give the inhaler in the buccal cavity. So every time the steroid get absorbed from buccal cavity as well as from the GIT, so there is also systemic absorption. So there is also a systemic absorption of steroids whenever you give medicines by inhalational route, because you are putting the inhaler in a buccal cavity. So every time some steroids, not some steroid, rather most of the steroid will enter in your GIT, and from this GIT, this steroid get absorbed and can result in systemic side effects. And if we talk about systemic side effects of steroids, so this topic is side effects of steroids. So in central nervous system, these steroids can result in raised ICT. So steroids can result in raised ICT, can result in psychotic symptoms, Number two, in eyes, steroids can cause early maturation of lens. So it can result in posterior subcapsular cataract. Number three, steroids can also act in GIT and can result in increased risk of peptic ulcer disease. Number four, it can also act on musculoskeletal system. So steroid can also act on musculoskeletal system. So can result in atrophy of muscles, and can also result in osteoporosis. So can result in osteoporosis and atrophy of muscles. Steroids can also suppress the HPA axis. Steroid can also suppress the hypothalamic pituitary axis because of the negative feedback, right? So these are the some important systemic side effects of steroids. And one more side effect is on metabolic pathway. Steroids will cause hyperglycemia. So steroids can cause hyperglycemia as a side effect. So in last few years, they have asked about the side effects of beta 2 agonist. But this year, because there are chances that they have already asked about beta 2 agonist, so there are chances they might ask about the side effects of steroids. So please be careful. Now there is one exercise for you people. Okay, I think Dr. Gamma Knife, I have given the answer of your question. Right. So now you have to tell me the side effects of beta 2 agonist. Who will tell me the side effects of salbutamol? Anyone would like to answer? What are the side effects of salbutamol? This is an exercise for you people. We have discussed so many times. During our lecture. What are the side effects of beta 2 agonist? Because this question is very, very important. Asked last year also. And there is a possibility that question might be repeated this year also. Anyone would like to answer? Very good. So Dr. Faizan, Dr. Ritvik, Dr. Vijiraj, all of you have given the correct answer. So side effects you can remember by the mnemonic 3T and 3H. So 3 side effects starts with T, 3 side effects starts with H. So these medicines can cause tremors as the most common side effect. Medicines will also cause tachycardia. So tachycardia is a second most common side effect. These drugs can also cause tolerance. which is also known as tachyphylaxis. So medicines can cause tolerance, which is also known as tachyphylaxis. These drugs will cause hypokalemia. So medicines can cause hypokalemia. These medicines can cause hyperglycemia, can result in hyperglycemia, and can also result in hypotension rarely. So one rare side effect of medicine is hypotension. So these are the side effects of beta 2 agonist. Okay, now there is one more exercise for you people. There is one more exercise for you people. You have to tell me what is the treatment of choice for acute attack of bronchial asthma. Who will tell me what is the treatment of choice for acute attack of bronchial asthma? Anyone would like to answer? What is the treatment of choice for acute attack of bronchial asthma? Anyone? No, doctor, no. It's not salbutamol. There's a change here. Yes, Dr. Bhavin. So, Dr. Bhavin Tambolia, you have given the correct answer. Dr. Bhavin has given the correct answer. Dr. Umang. Yes, Bhavin, Umang, Gamma Knife. Not Gamma Knife, please check your answer again. Very good. So, the answer is we give a combination of a steroid, that is budesonide. So, budesonide is inhalational steroid, and we give this medicine along with formoterol. So formoterol is a drug that is a LABA. So this combination is preferred. So budesonide plus formoterol combination is nowadays preferred for the treatment of acute attack of bronchial asthma. If it is not given to you, then you can go for salbutamol. So salbutamol is now a second choice instead of this budesonide and formoterol combination. So Bhavin has given the first answer correctly. Very good, Bhavin, for this. Right. Now let's move on to the next question. Question number 4. A patient suffering from acute CHF should not be prescribed. Patients suffering from acute CHF should not be prescribed one of the following diuretic drug. What is the answer? So this is not a clinical question, just a fact-based question, but can be asked. Question number 4. They can ask you the side effects or contraindications of diuretics. Side effects and contraindications of diuretics. Anyone would like to answer? A patient suffering from acute CHF, the drug that should not be prescribed. Yes, so answer is very good. So Aditya Singh, Afsal, Ritvik, Rizwan, all of you have given yes, very good. Faizan, Pradeep, Zainab, Zain Khan, all of you have given the correct answer. So the answer is mannitol. So mannitol is a drug that is contraindicated. So please remember the contraindications of mannitol. So mannitol is a osmotic diuretic. This medicine is an osmotic diuretic. This medicine is an osmotic diuretic and given by IV route. So mannitol is an osmotic diuretic given by IV route. And if you give this medicine by IV route, this medicine remain in the circulation. Try to understand patient who is having the acute CHF. Patient who is having the acute CHF, the blood is not pumping the blood. So the heart is not pumping the blood. So heart is not able to pump out the blood in a sufficient manner. So what will happen when you give this osmotic diuretic by IV route? This will remain in the circulation. And when this osmotic diuretic remain in the circulation, when you have given it by IV route, it cannot reach at the level of kidney because the heart is not able to pump more blood. So what this mannitol will do? This mannitol keep on circulating in your vascular space, and because of this osmotic effect, this will start pulling out the water from the tissues. So mannitol will pull out the water from the tissues, body organs, and this will increase the volume of the blood. And when there is an increase in the volume of the blood, this will increase the congestion in patients of acute CHF. That's why this drug is contraindicated. So in patients of acute CHF, we should not give mannitol because this mannitol will remain in the circulation. It cannot reach up till kidney because heart is unable to pump sufficiently. So this will increase the volume of blood in the plasma. It will increase the plasma volume and increase the load on the heart. So already heart is compromised. This will precipitate the symptoms of acute CHF. The second contraindication where this medicine is not given. So if the patient is having acute active CNS bleed. So if the patient is having acute cerebral hemorrhage, so patient is having acute active CNS bleed or patient is having acute cerebral hemorrhage. So if you give this medicine during this case, during this acute bleeding which is going on, so if the artery is ruptured, if the patient blood vessel or the cerebral artery is ruptured, so this medicine will cross this blood vessel and enter in the brain tissue. And when this medicine will enter in the brain tissue, this will increase the osmotic effect. And because of this osmotic effect, this will pull the more water towards the brain tissue. So during this active bleeding which is going on, you should not give mannitol. Right? So there are two important contraindications of mannitol. One is acute CHF, second is acute active CNS bleed. And if you can remember, in patients of end stage renal disease, in patients of end stage renal disease, mannitol has no role because mannitol cannot act on kidney nephron because nephrons are not left in the kidney. So because nephrons are not left in the kidney, so in patients of end stage renal disease, if you give the medicine, medicine will remain in the plasma. Medicine cannot be excreted out of the body because the kidney is not functioning. That will cause more blood in the plasma, more volume of the plasma. That will cause hypervolemia. So three contraindications of mannitol we have discussed. Now what are the indications of mannitol? Anyone would like to answer? In which condition we give this medicine? So please remember, this medicine is drug of choice for cerebral edema. This medicine is drug of choice for cerebral edema when no active bleeding is taking place. So if there is no active bleeding taking place, this medicine is given to pull out the water from brain tissue. So in patients of cerebral edema, this is cerebral artery. Now the artery is intact. The bleeding has already taken place. The edema has already formed. The hematoma is already formed. So now if you give the medicine, this medicine will pull out the water and decrease the pressure on the brain structure. So it's a drug of choice for cerebral edema. It's a drug of choice for raised ICT. It's a drug of choice for raised ICT. This medicine is given in the treatment of oliguria also. So in patients of oliguria, we can give mannitol to increase the urine output. And also this medicine is given as a drug of choice for refractory cases of acute closed angle glaucoma. Also given as drug of choice for refractory cases of acute closed angle glaucoma. So it's a drug of choice for cerebral edema, drug of choice for raised ICT, also given for the treatment of oliguria, and this medicine is drug of choice for refractory cases of acute closed angle glaucoma. So most of you have given the correct answer. I am very much impressed with you people that you have given the correct answer, right? Okay, now come back to this question. Now there is one exercise for you people. So every time I will tell you the crux of the question and I will give you one exercise with all questions, right? You have to answer me those questions. Now the exercise is, you have to tell me out of these three medicines which are given for the treatment of CHF. So these medicines can be used in the treatment of CHF. Who will tell me which is the most preferred medicine for acute CHF associated with pulmonary edema? So the patient is having acute CHF with pulmonary edema. Patient is having acute CHF, and any patient suffering from CHF, you people must be knowing the heart is unable to pump blood. So blood will start accumulating in lungs, and when this blood will start accumulating in lungs, we call it pulmonary edema. Because of the back pressure, blood will accumulate in lungs, we call it pulmonary edema. So which is the best medicine to be started here? Is it mannitol or something else? Yes, the answer is furosemide. Very good. So most of you have given the correct answer. Dr. Nitesh Sharma, please check your answer. If you have any doubt, please ask me right now. So furosemide is overall drug of choice for acute CHF with pulmonary edema. So furosemide is a preferred medicine in this case, right? So that is all about question number 4, right? Last year they have asked a questions from diuretics. So they asked about the drug of choice for mountain sickness. So who will tell me which medicine is drug of choice for mountain sickness? Which medicine is drug of choice for mountain sickness? Also, you have to tell me which medicine is drug of choice for ascites edema. Which medicine is drug of choice for ascites edema? Answer me these two questions. What is the drug of choice for mountain sickness? Answer is acetazolamide. So acetazolamide is drug of choice for mountain sickness, high altitude sickness. It's acetazolamide. And also you have to tell me which medicine is drug of choice for edema associated with liver disease. So patient is having liver disease, liver cirrhosis. So liver cirrhosis associated edema, ascites edema. Which medicine is the best medicine for ascites edema? Anyone would like to answer? No, Dr. Ehtesham Zafar, it's not mannitol, it's something else. Think about a drug. Very good. So Dr. Afsal, Dr. Sujit Kumar has given the correct answer. The answer is spironolactone. So the medicines like spironolactone is the best medicine, or potassium sparing diuretics are the best medicine for the treatment of ascites edema. So now you should be very clear about the different types of edema, and you should be knowing which medicines are given for a particular edema. So ascites edema, we give spironolactone, right? For pulmonary edema associated with CHF, we give furosemide. But for cerebral edema, we give mannitol. Understood? So drug of choice for pulmonary edema associated with CHF, we discussed already, it's furosemide. For pulmonary or for cerebral edema, it's mannitol. So different types of edema, you have to answer different drugs. So cerebral edema, it's mannitol. Pulmonary edema with CHF, it's furosemide. And if pulmonary edema is because of some other cause, you have to treat the cause accordingly. For example, patient is having tuberculosis. So tuberculosis can also cause pulmonary edema. So you have to treat the tuberculosis instead of giving some diuretics, right? Next is question number 5. So question number 5, a 55-year-old diabetic patient who is also having bilateral renal artery stenosis. So 55-year-old patient, old patient hai. Second is patient is also diabetic. So first thing to consider is this. Second thing to consider is this. Third thing is this. The patient is having bilateral renal artery stenosis. Fourth thing to consider is this. Patient has come to an OPD. There is no emergency. There is no emergency here. The fifth is patient BP is 150/94. So which antihypertensive is best to start here? So which antihypertensive is the best medicine to start here? So what is the answer? Okay, let me ask you a question like this way. Can we give enalapril? Yes or no? If you say no, you should give the reason. Why enalapril is not the best medicine to be started here? Why enalapril is not the best medicine to be started here? The answer is yes. So enalapril is an ACE inhibitors, and ACE inhibitors are contraindicated in a patient who is suffering from bilateral renal artery stenosis. So in patients of bilateral renal artery stenosis, ACE inhibitors are contraindicated. So yes, most of you have given the correct answer. So Zain Khan, Satish Kumar, you've given the correct answer. So enalapril is ACE inhibitor, should not be given in patients of bilateral renal artery stenosis. Now propranolol is a drug. This medicine is generation 1 beta blocker. This medicine is generation 1 beta blocker, and this medicine can result in hyperglycemia. So one of the side effect of generation 1 beta blocker, the old medicine, is hyperglycemia. And because the patient is diabetic, we should not start propranolol in this patient. We should not start propranolol in this patient because medicine can cause hyperglycemia as a side effect. Now hydrochlorothiazide is a thiazide. One of the long-term complication of thiazide therapy is metabolic complications. So metabolic side effect is hyperglycemia. So because of this hyperglycemia, thiazide is also not very appropriate to be started here. But if we talk about this medicine, amlodipine. So amlodipine is the medicine, that's the best medicine to be chosen for the treatment of this patient. So please remember, this patient is old patient. So in old patient, generally we prefer to use calcium channel blockers. Also this patient is stable, and the most commonly used calcium channel blocker is amlodipine. It's the best answer of this question. So this question is based on how to choose antihypertensive drugs. So hypertension is a very important topic for your exam. So read antihypertensive in detail. Each and every drug of hypertension is important for you. Now you have to answer me few questions. You have to tell me what are the side effects and contraindications of ACE inhibitors. Anyone would like to answer? This is the first exercise for you people. You have to tell me side effects and contraindications of ACE inhibitor. I will give you one hint. There is a mnemonic to memorize these side effects and contraindication. The mnemonic is captopril. So you have to tell me the full form of side effects and contraindications of ACE inhibitor. Also, you have to tell me one more thing. If I say all ACE inhibitors are prodrugs, all ACE inhibitors are prodrugs except two drugs which are not prodrugs. You have to tell me the names of these two medicines. So this question is for you people now. You have to tell me the full form of captopril. What are the side effects and contraindications of ACE inhibitor? Also, you have to tell me all ACE inhibitors are prodrugs except which two medicines which are not prodrugs. Except two medicines which are not prodrugs, you have to tell me the names of those drugs. So for side effects and contraindications, C stands for dry cough. So these medicines can cause dry cough as the most common side effect. Medicines can also cause angioedema. So these side effects are due to the excess of bradykinin. So these two side effects occur as a side effect as a result of bradykinin accumulation. So medicines can also cause hyperkalemia. So potassium level will increase. These medicines can cause taste change, typically captopril. O stands for orthostatic hypotension. So O stands for orthostatic hypotension. P stands for pregnancy. But please remember, pregnancy is a contraindication. Pregnancy is a contraindication. So next is renal artery stenosis, typically the bilateral. So it is also a contraindication. So there are two contraindications which we have discussed. Third contraindication is if the patient creatinine level is already more than 2.5. Patient creatinine level is already more than 2.5. Medicine is contraindicated. And these medicines can cause skin rashes, and skin rashes are red in color, so we call it lal in Hindi. So red is known as lal in Hindi, so we call it lal skin rashes or red skin rashes as a side effect. So side effect and contraindications. So three contraindications we have discussed here. There are three contraindications which we have discussed over here, right? The first one is pregnancy, second is renal artery stenosis, the third is increased level of creatinine. And all ACE inhibitors are prodrugs except two medicines, and these two medicines are lisinopril and captopril. So all ACE inhibitors are prodrugs except lisinopril and captopril. Lisinopril and captopril. Now there is one more exercise for you people, because this topic is very important, and every year you get one MCQ out, not one, two MCQ out of this antihypertensive topic. You have to tell me which antihypertensive is approved for the treatment of insulinoma. Which antihypertensive is approved for the treatment of insulinoma? Which antihypertensive can cause SLE side effect? Which antihypertensive can cause SLE as a side effect? Number 3, you have to tell me which antihypertensive is also given for the treatment of alopecia. Which antihypertensive is given for the treatment of alopecia? Third question for you people. The fourth question for you people is, what is the drug of choice for hypertension? Which group of medicines are best medicines for the treatment of hypertension in young patients? So in young patients, which medicines are the best medicines to be started? Fifth question, which medicine is approved for the treatment of subarachnoid hemorrhage? Which antihypertensive is approved for subarachnoid hemorrhage? And the last question for you people, which angiotensin receptor blocker has antiplatelet property? Which angiotensin receptor blocker has antiplatelet property? You have to answer me these 6 questions. Very good. So most of you have given the correct answer. So insulinoma treatment, we give a drug, the name is diazoxide. So diazoxide is a medicine that is useful. SLE is a side effect of hydralazine. Alopecia, we use minoxidil. We use a drug minoxidil. In young patients, ACE inhibitors are the preferred medicine to be started. Subarachnoid hemorrhage. Subarachnoid hemorrhage, we can use a drug, the name is nimodipine. So nimodipine is a drug that is given for subarachnoid hemorrhage. And angiotensin receptor blocker which has antiplatelet property is losartan. So losartan is an angiotensin receptor blocker which has antiplatelet property. So topic of hypertension is very important. Next question I have also put on the same antihypertensive drugs. You have to tell me. You have to tell me this question. In pregnant females, which antihypertensives are safe and which antihypertensive is not safe? Which antihypertensive is safe, which is not safe? So this question is based on PIH, the drug safety in pregnancy. So drug safety in pregnancy, anyone would like to answer? So Dr. Imran, Dr. Umapathy, very good. So most of you have given the correct answer. Telmisartan. So telmisartan is contraindicated. So ACE inhibitors and ARBs are contraindicated. So the question is based on which drug is unsafe. So answer is A, telmisartan. So please tell me which medicines are safe to use in patients of PIH. Which antihypertensives are safe to use in patients of PIH? Give me the names of drugs. I want 6 names. I want the names of at least 5 medicines, not exactly 6, 5 medicines. 5 medicines names I want, which are safe to use in patients of PIH. So the answer is labetalol. So labetalol is a drug of choice. We can also use alpha methyl dopa. So alpha methyl dopa is a second drug of choice which we can use after labetalol. Other medicines which we can use are hydralazine. One more medicine is nifedipine. So these 4 medicines are commonly used, but apart from that, we can also use medicines like prazosin. So prazosin can also be given, and clonidine. So prazosin, clonidine can also be used. So these are the 6 medicines which are safe. Rest of the medicines are comparatively unsafe. We should not use those medicines. Right? Now there is one more question for you. Out of these 6 medicines, who will tell me? Out of these 6 medicines, who will tell me which medicine can cause positive Coombs test? Which medicine can result in positive Coombs test as a side effect? Which medicine use is associated with positive Coombs test? Anyone would like to answer? Answer is methyl dopa. So alpha methyl dopa is a drug which can result in positive Coombs test. So to some extent hydralazine can also cause. But the best answer, the maximum risk is with methyl dopa, and that is why this medicine will cause hemolytic anemia, autoimmune hemolytic anemia. The next question, question number 7. So question number 7 is an important question. So this is an expected MCQ for this year exam regarding this drug, not exactly the same language of the question, but I mean, the drug group can be asked this year. Anyone would like to answer? So, a 55-year-old suffering from hypertension as well as grade 2 heart failure. So, suffering from hypertension and heart failure. Now, you have started a combination of a drug that is inhibitor of angiotensin receptor, as well as that drug is inhibitor of neprilysin enzyme. So, that is a inhibitor of neprilysin enzyme and angiotensin receptor. So, this medicine can control patient blood pressure as well as reduce the risk of mortality in CHF and also reduce the incidence of hospitalization, which is this combination which we use nowadays very commonly for the treatment of CHF. So, the answer is yes, the answer is this sacubitril plus valsartan combination. So, sacubitril plus valsartan combination is important MCQ for this year exam. This is also known as ANRI, right? So, A stands for angiotensin and neprilysin inhibitor. So, angiotensin and neprilysin inhibitor, so it's a combination of sacubitril. So, sacubitril is inhibitor of neprilysin enzyme, valsartan is angiotensin receptor blocker, and this combination we use for the treatment of CHF, and results are very good. This will reduce the overall risk of mortality and also reduce the incidence of hospitalization in a patient. So, this is an important question for this year exam. Question number 7 we have covered, right? Now, if I ask you this question based on topic CHF, so in patients suffering from CHF, if I ask you this question, there is one drug digoxin, right? Who will tell me what are the risk factors for digoxin toxicity? What are the risk factors for digoxin toxicity? Anyone would like to answer? What are the risk factors for digoxin toxicity? What are the various risk factors which can cause digoxin toxicity? Anyone would like to answer? So the factors are: number 1, hypercalcemia, second is hypokalemia, third is hypomagnesemia, fourth is CKD, and the fifth is old age. So these are the 5 important risk factors for digoxin toxicity. So digoxin toxicity, the risk factors are hypercalcemia, hypokalemia, hypomagnesemia, CKD, and old age. These are the 5 factors which can cause digoxin toxicity. It's not hyperkalemia. So most of you are writing hyperkalemia, but it's not hyperkalemia, it's hypokalemia. Hypokalemia is a risk factor. Hypokalemia is a risk factor for digoxin toxicity, right? And please remember the most common side effect. The most common side effect of digoxin is GIT side effects. So GIT side effects are the most common side effect of digoxin toxicity, right? Next question for you people, question number 8. A 48-year-old male patient arrived at hospital emergency. So patient has arrived at hospital emergency. Male patient arrived at hospital emergency with acute MI. So arrived with acute MI in unconscious state. Now this patient is immediately put on oxygen. You have given a thrombolytic therapy so that the clot is dissolved because of case of acute MI, and also you have given antiplatelet drug. Now which of the following antiplatelet drug can be a part of above treatment given to this patient? Right? I will give you one hint to solve this question. This patient is unconscious. This patient is unconscious, so cannot take medicine by oral route. This patient is unconscious, so cannot take medicine by oral route. So ideally the answer should be aspirin, right? But in this case aspirin cannot be given because aspirin is given by oral route and patient is supposed to chew the medicine if taken by oral route. So patient is supposed to chew the medicine, but in this case the patient is unconscious. In this case the patient is unconscious, so you cannot give medicine by oral route. You have to choose a drug that can be given by non-oral route. Which medicine can be given by non-oral route? So in this case the patient is unconscious, it's an acute emergency. So during acute emergency we have a group of antiplatelet drugs. We have a group of antiplatelet drugs, we call them glycoprotein 2b3a inhibitors. We call them glycoprotein 2b3a inhibitors. So glycoprotein 2b3 inhibitors, these medicines are given by IV route. So this medicine can be the antiplatelet drug which can be given for the treatment of this patient, right? So the answer is FMGE because the patient is unconscious. Now regarding this question, please remember all antiplatelets are given by oral route, but FMGE is a drug which is given mainly by IV route. So answer is C. Now regarding this question, you have to answer me few questions more regarding antiplatelet drugs. The drug is aspirin. So who will tell me the mechanism of action of aspirin as an antiplatelet drug? What is the mechanism of action of aspirin as an antiplatelet drug? Right? So the second is clopidogrel. Now who will tell me the names of other drugs of this group? So names of other drugs which belongs to this group of clopidogrel. Also you have to tell me regarding the fourth medicine, dipyridamole. So what is the important side effect of dipyridamole? Tell me the mechanism of action of aspirin used as an antiplatelet drug. Very good. So aspirin is used in low dose. Aspirin is used in low dose. It's an inhibitor of COX-1 enzyme. Aspirin is used in low dose. It's an inhibitor of COX-1 enzyme. And by inhibiting the COX-1 enzyme, this will reduce the level of thromboxane A2. This will reduce the level of thromboxane A2, and this is the mechanism of action of this drug as an antiplatelet. So by inhibiting the thromboxane A2 synthesis, so thromboxane A2 synthesis is reduced by inhibiting the COX-1 enzyme. What are the names of drugs which are other than clopidogrel? So we discussed a mnemonic during our lecture, that is tick tick dog. So in clopidogrel we have the name dog, and there are two more drugs like tick tick dog, right? So tick tick means ticlopidine. Other drugs of this group are ticlopidine, and one more drug is ticagrelor. So ticagrelor and ticlopidine are two more medicines which belong to this class. And one of the important side effect of dipyridamole is coronary steal phenomena. So I'm really impressed that you people remember all this. Dr. Arnab Datta, all of you have given the correct answer. Dr. Agustin, Dr. Afzal Apsu, all of you have given the correct answer. Dr. Shimran, Dr. Rizwana. So correct answers. So coronary steal phenomena is a side effect of dipyridamole. That is all about this antiplatelet drugs. Next question is based on anticoagulants. Next question is based on anticoagulant drugs. So anticoagulant medicines, question number 9. A 60-year-old patient suffering from severe osteoarthritis. 60-year-old patient suffering from osteoarthritis admitted for TKR. So patient is admitted for TKR surgery. Now after the surgery is successfully performed, patient was put on low molecular weight heparin. Patient was put on Patient is put on low molecular weight heparin as an anticoagulant drugs to prevent thromboembolic complications. Now when patient were discharged from hospital after 6 days, post surgery, he was put on some oral anticoagulant medicines. Now which oral anticoagulant is best to start in this patient? Difficult question. Okay. So how to solve these questions? Try to understand. whenever patient is suffering from hypercoagulation, whenever patient is suffering from hypercoagulation, or if and patient is in acute emergency, or patient is admitted in hospital, so patient is admitted in hospital, there is acute emergency, patient is suffering from very severe disease, patient is suffering from very severe disease, so patient is suffering from hypercoagulation, patient is at high risk, patient is high risk patient, so risk of thromboembolism is very high, patient is suffering from acute emergency, patient is admitted in hospital, any of this scenario is given, blindly go for low molecular weight heparin. So low molecular weight heparin is the best medicine to be started in acute emergency. And if we talk about heparin, all heparin drugs end up with the word parin. So all these medicines have parin in their last. So low molecular weight heparin is a drug of choice for acute emergency, patient who is admitted in hospital, patient is having severe disease, or patient is high risk patient. Right? Now once this patient gets stabilized, so once this acute patient gets stabilized, so once the patient gets stabilized after you've given the low molecular weight heparin, right? Now you have to discharge this patient on oral anticoagulant. You have to discharge this patient on oral anticoagulant. And when you want to give oral anticoagulant medicine to this patient, please remember you have to give medicines which are direct factor 10 inhibitors. So you have to give medicines which are direct factor 10 inhibitors by oral route. So these medicines name end up with XA-ban. So all these medicines name end up with the word XA-ban, that is factor 10A ban. Or you can give factor 2 inhibitor by oral route. So factor 2 inhibitor given by oral route. So this is only one drug, dabigatran. So you have to choose any of these medicines. So nowadays, what is the recommendation? During acute emergency, as long as patient is not stabilized, patient is in high risk patient, patient is admitted in hospital, severe disease is there, risk of embolism is very high, you give low molecular weight heparin by IV route so that the patient gets stabilized. And how you recognize this low molecular weight heparin? You will find the word parin in their names. Now once the patient is stabilized, you have to put patient on oral anticoagulant and discharge the patient from hospital. Now for oral anticoagulant, it used to be warfarin. It used to be warfarin, but nowadays the warfarin is not the preferred medicine. So warfarin has become the second or third choice now. So nowadays we prefer to use factor 10 inhibitors. So any medicine that is factor 10 inhibitors, all medicines are given by oral route, and all these medicines have the word XA-ban in their name. Right? XA means factor 10A is banned. So there are the direct factor 10 inhibitors. Or there is only one factor 2 inhibitor which can be given by oral route. The drug name is dabigatran. The drug name is dabigatran, which can be given. If any of this option is not there, then you can give warfarin. Now there are two exceptions to the above rule. There are two exceptions to the above rule. And what are the two exceptions? So be careful about the exception. The first exception is if patient has undergone the prosthetic heart valve surgery. So patient has undergone valve replacement surgery, or patient has implanted the prosthetic heart valves. So in cases of prosthetic heart valves, instead of starting with these new medicines like factor 10 inhibitors or factor 2 inhibitors, better to give warfarin. The second is the pregnancy. So if the female is pregnant, then again these new medicines which are factor 10 inhibitors or factor 2 inhibitors, these medicines safety is not established. So in pregnant females, the medicine safety is not established. So in pregnancy, we follow a different guidelines. So in pregnancy, we follow a different guidelines. So in first trimester, we give low molecular weight heparin. If it's the first trimester, we continue low molecular weight heparin. And for second and third trimester, we give warfarin. For second and third trimester, we give warfarin. And at 36 weeks, we again put female on low molecular weight heparin. So if the female is pregnant and you want to discharge this female, if the female is having the first trimester going on, give heparin. The female is having second and third trimester, give warfarin. And 36 weeks, you again put female back to low molecular weight heparin. So please be careful what exactly they have asked in the question. So please, again, I'm repeating it again. Whenever there is a risk of hypercoagulation or whenever there is a risk of venous thromboembolism, whenever there is a risk of venous thromboembolism, you have to assess the patient condition. If there is acute emergency, if there is patient admission in the hospital, patient is having the severe disease, patient is under the category of high risk patient, give heparin or the mark heparin as a best medicine to be started. As long as you will give the medicine till the time patient gets stabilized, and once patient gets stabilized, you have to discharge the patient from hospital. Then you have to put patient either on factor 10 inhibitors or factor 2 inhibitors, that is only dabigatran by oral route. So these medicines are given by oral route. Now there are two exceptions to this rule. The first is the patient is having valvular heart surgery, then the risk of hypercoagulation is there. So instead of giving the above medicine, you give warfarin. The second is the pregnancy. In pregnancy, we have the different guidelines. In first trimester, heparin. Second and third trimester, warfarin. And at 36 weeks, you again put female back to low molecular weight heparin. Right? Now, answer me this question. Now, first of all, you have to tell me that all these medicines belongs to which class? So if we talk about this medicine, enoxaparin, so this is a low molecular weight heparin, right? Now if we talk about this lepiridine and dabigatran, these are the factor 2 inhibitors. These medicines are factor 2 inhibitors. We call them direct thrombin inhibitors. We call them direct thrombin inhibitors, right? Direct thrombin inhibitors. So all these medicines are given by IV route except dabigatran, which is given by oral route. So now choose the best answer. The best answer here is dabigatran. So the best answer here is dabigatran, which you have to choose in this patient, because this patient is not pregnant, the first thing. Also, this patient has not undergo any valve replacement surgery. This patient has not undergo any valve replacement surgery. This patient has undergone knee replacement surgery. Also, this patient is not pregnant. So there is no point of answering the warfarin or any other drug. Just think about factor 10 inhibitors or factor 2 inhibitor given by oral route, that is dabigatran. Right? So the answer is dabigatran. So if I ask you this thing, how you will recognize factor 2 inhibitors? So if we talk about factor 2 inhibitors, so what is the name of factor 2? Factor 2 is known as thrombin. Factor 2 is also known as thrombin. So these medicines are also known as direct thrombin inhibitors. So these medicines we have derived from leech. So leech is a blood sucking parasite. So we have derived these medicines from the saliva of leech, that is known as hirudin. We call it hirudin. So all these medicines are having the rudin word in their name. All these medicines have rudin in their names. For example, lepirudin, bivalirudin. So bivalirudin, lepirudin. So rudin is derived from hirudin. Now apart from that, we have a drug known as ergotroban. We have one more medicine here that is known as ergotroban. So ergotroban is a drug having the word tro. So tro is for thrombin, ban is for ban. So thrombin is ban. So thrombin is ban. So ergotroban is also factor 2 inhibitor. And the last is dabigatran. So even if you look at the dabigatran, dabigatran has the word TR. So TR is for thrombin, AN is for antagonist. So it's a thrombin antagonist, factor 2 antagonist. And also this drug is having the word bi. Bi stands for factor 2. So it's a factor 2 inhibitor, thrombin antagonist. And it is the only drug over here, which is given by oral route. All other medicines are given by IV route. So that is all about these guidelines of anticoagulants and how to recognize anticoagulants whenever they asked in exam. Let's move on to the question number 10. So if we talk about question number 10, a patient suffering from esophageal carcinoma. A patient is suffering from esophageal carcinoma, admitted in hospital for a chemotherapy cycle. Admitted in hospital for chemotherapy cycle, that is platinum based. So admitted in hospital for platinum based chemotherapy cycle, right? And obviously you must be knowing the platinum drug is cisplatin. The platinum here means cisplatin. So patient is taking cisplatin based regimens for cancer, esophageal cancer. Now we know that this medicine can cause lot of vomiting. We call it chemotherapy induced nausea vomiting. So this medicine will cause chemotherapy induced nausea vomiting. And you have to tell me, to prevent this complication, before chemotherapy cycle, you have to give some drugs. So you have to give some medicines that will stop or that will prevent the vomiting. So the medicines that are given before the chemotherapy cycles to prevent the vomiting. So which medicine should not be a part of this regimen? So please remember, if we talk about chemotherapy induced vomiting, so there is one early chemotherapy induced vomiting, and drug of choice for that is 5-HT3 blockers. So 5-HT3 blockers are the best medicines for early chemotherapy induced vomiting, and the best medicine nowadays is palinocetrone. So palinocetrone you will give to prevent early vomiting. Also there is one delayed vomiting. There is one delayed vomiting that will start after 24 hours, and for delayed vomiting we will give neurokinin 1 receptor antagonist or substance P inhibitor like aprepitant. So we can give aprepitant, that is substance P inhibitor, for delayed vomiting. Now please remember, if a question will come to you, what is the second drug of choice for delayed vomiting? What is the second drug of choice for delayed vomiting? So please remember, for second drug of choice for delayed vomiting is steroids. And among steroids, we prefer to give dexamethasone. So dexamethasone is also used as an anti-emetic drug. It is also used as an anti-emetic drug to stop the vomiting or to prevent the vomiting. Right? So three medicines which can be a part of this regimen are palinocetrone. Palinocetrone belongs to a class of ondansetron group. So nowadays we are using palinocetrone. Aprepitant is substance P inhibitor or neurokinin 1 blocker. It's a drug of choice for delayed vomiting. And we can also use steroids. So in this question, the best answer is domperidone. So domperidone is a very weak antiemetic drug. Domperidone is a very weak antiemetic medicine. This medicine cannot control the vomiting caused by cisplatin. So it cannot control the vomiting caused by cisplatin. Rest of the medicines are typically meant for chemotherapy induced vomiting. So best answer here is domperidone. So I suggest you, in topic of GIT, concentrate on two main things. One is the treatment of nausea and vomiting. Second, they can ask you the drugs which are given for GERD. So drugs for GERD is important. Anti-emetic drugs are important for your exam. And please remember about a drug misoprostol. So misoprostol is a drug for peptic ulcer disease. This can also be asked. So three important topics in GIT: nausea, vomiting, GERD and misoprostol. So let me give you one exercise. You have to answer me few questions. First question is which antiemetic can cause a side effect of extrapyramidal symptoms? Which antiemetic can cause side effect as extrapyramidal symptom? Also you have to tell me what is the drug of choice for morning sickness. What is the drug of choice for morning sickness? Second question. Third question, you have to answer me which antibiotic is approved for the treatment of GERD? Which antibiotic is approved for the treatment of GERD? You have to answer me this question. So three questions you have to answer. Which antiemetic can cause extrapyramidal symptoms? So the answer is metoclopramide. So the answer is metoclopramide. This medicine is dopamine blocker, and by blocking dopamine pathway, this medicine can cause extrapyramidal symptom. Drug of choice for morning sickness is doxylamine. Drug of choice for morning sickness is doxylamine. So most of you have given the correct answer. Doctor, it's not mountain sickness, it's morning sickness. Morning sickness occurs in pregnancy. So you give doxylamine along with vitamin B6. And the antibiotic that is approved for GERD is erythromycin. So erythromycin is a drug. This medicine can increase the peristalsis. This medicine can increase the peristalsis and having the prokinetic properties. So this drug has prokinetic properties and given for the treatment of GERD. So this medicine can be given for the treatment of GERD. So that is all about this topic, GIT. So in GIT, important things are treatment of nausea, vomiting, GERD and misoprostol drug. Who will tell me misoprostol का teratogenic effect क्या है? What is the teratogenic effect of misoprostol? So misoprostol can cause one teratogenic effect. Who will answer me that thing? What is the name of the syndrome caused by misoprostol? What is the name of the syndrome caused by misoprostol? Which teratogenic effect? I will give you one hint that teratogenic effect starts with alphabet M. So misoprostol starts with M, and the teratogenic effect also starts from M. Anyone would like to answer? Or you people are tired? Or should I stop asking questions from you people, right? Should I stop asking question? Okay, yes, it's a Mobius syndrome. Very good. So the answer is it's a Mobius syndrome. So Mobius syndrome is a teratogenic effect caused by misoprostol. Next question is question number 11. A 45-year-old diabetic patient, 45-year-old diabetic patient who is quite non-compliant with his anti-diabetic drug treatment. Anti-diabetic drug treatment, patient is non-compliant. Non-compliant means patient is taking medicine on and off, not regularly, not properly, as well as he is not very compliant with lifestyle modification, dietary modification. And also because of this non-compliance, patient has history of 2 episodes of unconsciousness due to hypoglycemia. So any person who will not take medicines properly, do not follow the proper lifestyle modification or dietary regimens, there is a risk of unconsciousness because of hypoglycemia, right? So which medicine, because due to this such a complicated history, such a poor history of a diabetic patient, now which medicine should not be a part of his anti-diabetic treatment? Perfect answer. So most of you have given the correct answer. Guys, do you know one thing? I didn't expect that you will be able to answer this question. But I really appreciate that you have picked the crux of this question. So please remember, there are some anti-diabetic drugs which will not cause hypoglycemia. Because this patient has high risk of hypoglycemia and hypoglycemia is life threatening. So these are the 3 group of medicines where the hypoglycemia risk is very, very low. 3 group of medicines where the risk of hypoglycemia is very, very low. So these 3 group of medicines can be a part of this anti-diabetic regimen. But glipizide is a sulfonylurea. This medicine, most common side effect of this medicine is hypoglycemia. The most common side effect of this medicine is hypoglycemia, right? So that's why this medicine should not be a part of the above regimen. Now here you have to answer me few questions. So there is one exercise for you people. You have to answer me the side effects of metformin. You have to answer me the side effects of metformin, side effects of liraglutide, and side effects of pioglitazone. Who will tell me the side effects of metformin, liraglutide, and pioglitazone? Let me tell you, liraglutide is a drug. It's a GLP-1 analog. This medicine is GLP-1 analog. What are the side effects of these medicines? Anyone would like to answer? So metformin side effects. If I ask you this question, what is the most common side effect of metformin? If you take the metformin tablet, you will develop nausea. So nausea is very common with metformin. This medicine will also cause vitamin B12 deficiency, can result in vitamin B12 deficiency. Number 3, this medicine can also cause weight loss. Number 4, this medicine can also cause lactic acidosis. So lactic acidosis, weight loss, vitamin B12 deficiency, and nausea. Liraglutide is a drug. This medicine can also cause weight loss as a side effect. So this is also approved for obesity. Liraglutide is also approved for obesity. This drug can also cause pancreatitis. So medicine can cause pancreatitis. Number 3, this medicine can also result in increased risk of thyroid medullary cancer. This can also increase the risk of thyroid medullary carcinoma. So weight loss, pancreatitis, increased risk of medullary carcinoma. Now if we talk about pioglitazone can increase the risk of bladder carcinoma. Pioglitazone can also increase the risk of CHF, and this medicine can also result in bone fracture. can result in bone fracture, right? So these are the some important side effects of anti-diabetic drugs. Now, who will tell me which medicine is this? You have to tell me about canagliflozin. So tell me about mechanism of action of canagliflozin as well as side effects of canagliflozin. Who will tell me about this? Mechanism of action of canagliflozin and what are the side effects of canagliflozin. So please remember, mechanism of action of canagliflozin is it is a SGLT2 inhibitor. So this medicine can cause loss of sodium and glucose. So this group of medicine can cause loss of sodium and glucose. And because of this loss of sodium and glucose, medicines can cause weight loss. So this medicine can cause weight loss, increased risk of UTI because of continuous presence of glucose in urine. So increased loss of sodium will cause hyponatremia, can result in hypotension, and this medicine can also increase the risk of limb amputation. So this medicine can also increase the risk of limb amputation. So most of you have given the correct answer. Dr. Suraj, Dr. Bhavin, all of you have given the correct answers. Now there is one question for you people. So one question you have to answer me. Which DPP4 inhibitor, the medicine which is known as gliptin, medicines which are known as gliptins. So which DPP4 inhibitor is safe to use in patients of CKD? So which DPP4 inhibitor is safe to use in patients of CKD? Anyone would like to answer? Which DPP4 inhibitor is safe to use in patients of CKD? Which DPP4 inhibitor is safe to use in patients of CKD? Anyone would like to answer? Okay, let me tell you. The answer is liraglutide. Sorry. The answer is linagliptin. So linagliptin is a drug we discussed during our lecture also. Linagliptin starts with alphabets L and I. This starts with alphabets L and I, so it is metabolized by liver. This drug is metabolized by liver, so it is safe to use in patients of CKD. So in patients of CKD, this is comparatively safe to use. So question number 11 we have discussed on based on anti-diabetic drug, right? So linagliptin starts with Li. It is metabolized by liver, not by kidney. So it is safe to use in patients of kidney disease. Question number 12. A 38-year-old unmarried female, 38-year-old unmarried female belongs to high status family and has strong history of breast carcinoma reported in her mother as well as sisters. Now comes to you in your OPD for the consultation to prevent future risk of disease. Which of the following drugs should be the best prescribed to her at this stage as a prophylaxis of breast cancer? Anyone would like to answer? Out of these medicines, which is approved for prophylaxis of breast cancer? That is given for treatment also, but also approved for prophylaxis of breast cancer. So the answer is tamoxifen. So most of you have given the correct answer. Tamoxifen is the answer. So tamoxifen is a drug that is approved for the treatment as well as prophylaxis of breast cancer. So it's a wonderful drug to be given to a patient. Now there is one exercise for you people. You have to answer me these 4 medicines names which are written in front of you on your screen. You have to tell me these 4 medicines belongs to which particular class. So fulvestrant belongs to which class? Anyone? Fulvestrant belongs to which class? Ulipristal belongs to which class? Anyone would like to answer? Centchromin, what is centchromin? Belongs to which class? And tamoxifen belongs to which class? Anyone? If you know the class of any of these drugs, you can mention even randomly also. It's not like that you have to answer in sequence only. So randomly you can answer. Any idea? Fulvestrant belongs to which class? Okay, let me tell you. So fulvestrant is a drug. If you look at the name, its name end up with ANT. It's an antagonist. So fulvestrant is an antagonist. So ANT stands for antagonist. ESTR. ESTR, which is given in its name, it's a estrogen antagonist. This medicine is estrogen antagonist, and full is for full. It's a full estrogen receptor antagonist. It's a full estrogen receptor antagonist. We call it SERD. The full form is selective estrogen receptor down regulator. So it's the only drug which is selective estrogen receptor down regulator. Tamoxifen is a drug which is not a down regulator, it's a modulator. So any drug that ends with fen, any medicine that ends with fen is selective estrogen receptor modulator. So selective estrogen receptor modulator is a drug which ends up with the word fen, like tamoxifen, raloxifene, right, clomiphene. So all these medicines are having the fen. The third is ulipristal. Please remember, ulipristal is a drug having the word prist. So any medicine that has the word prist in its name, that medicine acts on progesterone pathway. So this medicine is a progesterone receptor modulator. It's a selective progesterone receptor modulator. So ulipristal is not a estrogen drug, it's a progesterone receptor modulator. And this is the most efficient emergency contraceptive pill. It's the most efficient emergency contraceptive pill which is taken after UPI. So this medicine is taken after UPI within 5 days. So patient can take medicine within 5 days after unprotected intercourse. So after unprotected intercourse, patient can take medicine up till 5 days. The dose of this medicine is 30 milligram. Right? Now if we talk about centchromin, now centchromin is also SCRM. Centchromin is a drug which is also a SCRM. Its actual name is ormelixifin. Its actual name is ormelixifin, so it's an SCRM. This medicine brand names are Saheli and Chaya. The brand names of centchromin is Saheli and Chaya, and this medicine can be used as an oral contraceptive pill. So this medicine is used as oral contraceptive pill. The drug is centchromin. Brand names are Saheli and Chaya. Right? So if you have any doubt regarding these medicines, please ask the question. If you have any doubt regarding these medicines, please ask the question. If we talk about only progesterone drugs here, because we have limited time. So if we talk about progesterone drugs, there are only 3 progesterone drugs which you have to remember. One is the progesterone analog. The drug name is levonorgestrel. So levonorgestrel is the most commonly used medicine for emergency contraception. Most commonly used medicine for emergency contraception is levonorgestrel, which is a progesterone analog. So if you look at the name of this medicine, norgestrel, it's a progesterone. So you can find out the name of this progesterone, it's a norgestrel. Second drug is SPRM. Second drug is not analog, it's a modulator. We call it SPRM. The drug is ulipristal. We have discussed already, this is also given for emergency contraception. It's a most efficient drug. It's not most commonly used, but it's a most powerful, most efficient drug. The third is antagonist. The third medicine is antagonist of progesterone. So the medicine which is antagonist of progesterone, also having the word prist in its name, the drug is mifepristone. So mifepristone is a drug which is used for MTP. This medicine is used for MTP for up till 9 weeks of pregnancy. So up till 9 weeks of pregnancy, we can use mifepristone. So these are the 3 progesterone drugs which are important for your exam. Rest of the medicines are estrogen pathway drugs. Right? Next is question number 13. A 55-year-old female comes to you with history of vertebral and hip fracture. So she has come to you with vertebral and hip bone fracture, and when you have done this BMD, bone mineral density test, her T-score is minus 3.0. So her T-score is minus 3.0, right? So it's a severe osteoporosis. So she is suffering from severe post-menopausal osteoporosis. So severe post-menopausal osteoporosis, right? Now you want to start a medicine to this female, which is a recombinant hormonal analog. So that medicine is recombinant hormonal analog, and that medicine has bone forming action. So that medicine has bone forming action. It means that medicine can stimulate osteoblasts. So bone forming drug can stimulate the osteoblast, and that drug is taken by subcutaneous route. That drug is taken by subcutaneous route. So which drug is that? So please remember, if we talk about osteoporosis, overall drug of choice for any type of osteoporosis, overall best medicines for any type of osteoporosis nowadays is bisphosphonates. So bisphosphonates are the best medicines overall for the treatment of any type of osteoporosis, whether it is menopausal, postmenopausal, male, female, any patient. So bisphosphonates are the best medicines to be started. But apart from bisphosphonates, we can start some other drugs also, especially in severe cases. For example, there is a parathyroid hormone analog. The drug is parathyroid hormone analog. The drug is PARA. So you can find out the name PARA. So it's a parathyroid hormone analog ending up with the word tide. So any drug which has tide in its name cannot be given by oral route. So any medicine which has tide in its name cannot be given by oral route because these drugs are peptides. So this is given by subcutaneous route on daily basis. The drug is parathyroid hormone analog, and it's the only drug. Please remember, it's the only drug which is a bone forming drug or anabolic drug. It's the only drug which is a bone forming drug or anabolic drug given for osteoporosis. Rest of the medicines like bisphosphonates. If we talk about bisphosphonates are not anabolic drugs for bones. Rather, these medicines are anti-resorptive drug. So there is only one drug which can cause bone formation. The rest of the medicines are inhibitor of osteoclasts. So rest of the medicines which are given for osteoporosis are only inhibitor of osteoclast. So if you inhibit osteoclast, automatically there is more activity of osteoblast. But there is one drug only which is a pure osteoblast stimulator. We call it anabolic drug. So please remember this, we call it anabolic drug for bones. The drug is teriparatide. Answer is B, Bombay. So question number 13, answer is B, which you have to mark. Right? Question number 14. Okay, before moving on to question number 14, please answer me one question. What is the most common side effect of bisphosphonates? What is the most common side effect of bisphosphonates? Number 2, what is a rare but important side effect of bisphosphonate? And third, which is the longest acting bisphosphonate? So you have to answer me 3 questions on bisphosphonate. Which one is longest acting bisphosphonate? What is the most common side effect of bisphosphonate? And which is a rare but very important side effect of bisphosphonate? Anyone would like to answer? Dr. Imran Ortho, Dr. Suraj Bhattacharya, Dr. Dilip Kumar. Very good. Dr. Guinea. So most common side effect of bisphosphonate is esophagitis. Most common side effect of bisphosphonate is esophagitis, and therefore after taking bisphosphonate, patient should remain in upright posture at least for 30 to 40 minutes. So most common side effect is esophagitis. The rare side effect but very important side effect is osteonecrosis. So this can cause osteonecrosis of jaw. So this can cause osteonecrosis of jaw, and rarely these medicines can also cause femur fracture. So fracture of femur head. So osteonecrosis of jaw as well as femur head fracture are two rare but important side effects. And the longest acting bisphosphonate is zoledronate. The longest acting bisphosphonate is zoledronate. Right? So that is all about this question. So let's move on to the next question. So we are running short of the time. So question number 14. So 28-year-old male who is a known case of epileptic disorder. So patient is a case of epileptic disorder, and for this epileptic disorder you have started phenytoin. So you have started phenytoin as an anti-epileptic drug. So all of these can be seen as a long-term side effect of this medicine except Which is not a long-term side effect of this phenytoin? Anyone would like to answer? Which is not a side effect of phenytoin? Yes, the answer is weight gain. Very good. So phenytoin will not cause weight gain. So weight gain is not a side effect. So weight gain is not a side effect of these medicines, right? So weight gain is a side effect of sodium valproate. It's a side effect of sodium valproate. So rest of the side effects can be seen with phenytoin. So this question is based on anti-epileptic drugs. Now I will give you one assignment. You have to answer me these questions. The first assignment is regarding the drug of choice. First assignment is regarding the drug of choice. You have to tell me which medicines are drug of choice for GTCS, right? Which medicine is drug of choice for atonic seizure, myoclonic seizure, right? Number two, you have to answer me which medicine is drug of choice for focal seizure. Number three, you have to answer me which medicine is drug of choice for absence seizure, typical and atypical both. Which medicine is drug of choice for typical and atypical seizure, right? Number four, you have to answer me which antiepileptics are safe to use in pregnancy. Which antiepileptics are safe to use in pregnancy. Also, you have to tell me what is a drug of choice for febrile seizure. What is a drug of choice for febrile seizure? So answer me these questions first. Yes. Okay. Now there are some clinical things which I think we should discuss over here. Guys, try to understand because there are many queries which I am receiving on day-to-day basis. Whenever patient is suffering from seizures or patient has come to you in OPD in acute state. If the patient has come to you in acute state, patient is having the active seizure, patient body is having the tonic-clonic jerks. So patient is in acute state. First of all, you have to stabilize the patient. If you start any of the antiepileptics are slow acting medicines. They take some time to build up the level in the CNS and then these medicines action will start. So whenever patient will come to you in acute stage, always first stabilize the patient, save the life of the patient. And whenever you have to save the life of the patient, always give benzodiazepines. So benzodiazepines are the best medicines to be given in acute stage to stabilize the patient. And among benzodiazepines, the most preferred medicine is lorazepam. Basically, antiepileptics required some time to build up their level in CNS. So lorazepam is the drug that will stabilize the patient for minimum 2 hours. So this medicine will give you the sufficient window so that the valproate level can be maintained in the CNS or the antiepileptic drug level can be maintained in the CNS. So this window you cannot get with diazepam. This window you cannot get with midazolam. So among benzodiazepines, the best medicine to be started is lorazepam. If it is not given in MCQ, give diazepam or midazolam to stabilize the patient. Now, once the patient is stabilized, you have to start maintenance drug of choice. So for GTCS, atonic seizures and myoclonic seizures, valproate is the drug of choice. If it is not given to in MCQ, you can go for lamotrigine. So lamotrigine is a second drug of choice which you can mark. For focal seizures, lamotrigine is the best medicine which you can mark, but you can also give other drugs like oxcarbazepine and carbamazepine, right? For typical absence seizures, you are supposed to mark ethosuximide. So ethosuximide is a drug of choice for typical absence seizure. For atypical absence seizures, you have to mark valproate as a best answer. The medicine which is safest to use in pregnancy is levetiracetam. So levetiracetam is a safe medicine to be used in pregnancy. And drug of choice for focal seizures, please remember, for focal seizures, there is no need to start some antiepileptics for 2 years or 3 years. Otherwise, patient will have lot of side effects. Febrile seizures are the one which will automatically controlled after 5 years, mainly after 5 years. So you have to, whenever patient has seizures, you have to just stabilize the patient. So you have to give benzodiazepine just to stabilize the patient. Now, how these benzodiazepines are given, that depends. If the patient is at home and parents have to give the medicine. Febrile seizure mostly occur in children. So if the parents have to give the medicine, they can give medicine by rectal route or by the nasal route. So rectal is diazepam and nasal is midazolam. Or if the kid has come to the hospital. Now as a doctor, you have to give medicine by IV route, either you give lorazepam or diazepam. So benzodiazepines are the best medicines for the febrile seizure. The patient is in hospital, you have to give medicine by parental route. Patient is at home, parents can give medicine by alternative routes like rectal or the nasal route. Right? Now there is one query which has come from Dr. Rahul. Dr. Rahul is, if typical or atypical is not asked in an exam regarding absence seizures, then what to mark? So Dr. Rahul, please remember, when it is not given to you whether it's a typical or atypical seizure, this is applicable to all diseases, right? So always consider that disease as a typical disease. If the MCQ is been asked on a disease and it is not given to you, it's a typical or atypical, always consider the answer that is given for the typical drugs. Right? Atypical, you will only think if it is given in MCQ, otherwise take that case as a case of typical absence seizure. And how will you find out, Rahul, that patient is having typical or atypical seizure? With the help of electroencephalogram. So with the help of electroencephalogram, if the wave's frequency is less than 3 Hz, if the frequency of the electroencephalogram wave is less than 3 Hz, it's a typical seizure. Or if it's a mixed pattern, sometimes it's less than 3, more than 3, mixed type of pattern is there. So if you will find the mixed pattern, it's a atypical seizure. Right? So Dr. Thanzi Zakir has asked, can we give paracetamol in febrile seizure? Dr. Thanzil, paracetamol has no rationale here because paracetamol is not an anti-epileptic drug. That medicine cannot control the seizures, first of all. Second, studies have shown this thing. At the time of high fever, patient develop the seizures. So if you give paracetamol, fever will start declining. Fever will start coming down. And if the fever will start coming down, the risk of seizure will increase. So risk of seizure increases when the fever is on the down pattern. So paracetamol has no rationale. If you want to give paracetamol, you can give it only to take care of fever. But as such, seizures, if you ask the drug for seizure, paracetamol has no rationale. Pregnancy. So one question is regarding pregnancy. In pregnancy, levetiracetam. Levetiracetam is safest of all. And if levetiracetam is not given in MCQ, go for lamotrigine. So lamotrigine is second safest medicine. Third is oxcarbazepine and carbamazepine. So medicines which are safe in pregnancy are levetiracetam, lamotrigine, oxcarbazepine and carbamazepine. Right? Understood? And which medicines are unsafe in pregnancy? So medicines which are unsafe in pregnancy are sodium valproate and phenytoin. So phenytoin and sodium valproate are unsafe in pregnancy. Now this question is regarding the side effects of anti-epileptic drugs. So I recommend you to read the side effects of anti-epileptic drugs directly from notes. So we have discussed side effects of anti-epileptic drugs so many times during our lecture, but still I would like to give you one exercise. Exercise is regarding the side effects of antiepileptics. So you have to answer me which antiepileptic can cause renal stone as a side effect. Which antiepileptic can cause PCOD as a side effect? Which antiepileptic can cause agranulocytosis? Which antiepileptic can cause hirsutism? And number 5, which anti-epileptic medicine can cause metaglaucoma? Which anti-epileptic can cause glaucoma attack? So answer me these 5 questions. So which anti-epileptic can cause renal stone, PCOD, agranulocytosis, hirsutism and glaucoma? Anyone would like to answer? Sujit Kumar Pandey. So Sujit Kumar Pandey, you have answered phenytoin. Phenytoin is answer of which out of these 5? Very good. So PCOD is caused by valproate. So Dr. Arnab. So Dr. Arnab has given the answer sodium valproate. Very good. Dr. Satish Kumar. Dr. Satish Kumar has said carbamazepine. Carbamazepine is the one that will cause agranulocytosis. So we have discussed some mnemonics if you remember. So valproate mnemonic is Vata plan. So in this mnemonic Vata plan, H stands for hormonal imbalance. In carbamazepine, we discussed a mnemonic of Cash. So in this mnemonic of Cash, A stands for agranulocytosis. Hirsutism is caused by phenytoin. Very good. Hirsutism is caused by phenytoin. Dr. Sujit Kumar Pandey has answered that renal stone is seen with topiramate. So topiramate is a drug which can cause renal stone, and even glaucoma. Glaucoma is also caused by topiramate due to its anticholinergic property. So topiramate is the one that can cause glaucoma because of its anticholinergic property. So this topic is very, very important. Anti-epileptic drugs, indications, side effects are very, very important for your exam. So every year you can expect MCQ out of this. Right? So please read all the side effects in detail. Question number 15. A patient with violent behavior and agitation has diagnosed with schizophrenia and prescribed haloperidol. Now on third day he developed rigidity and was unable to move his neck, that is fixed his stare to the one side. So patient neck is fixed on the one side because of the muscle spasm. So which treatment you can give to stabilize this patient? So first of all you have to tell me what exactly is this. So this question is based on antipsychotic drugs. So patient is having schizophrenia, you have started antipsychotic medicine haloperidol. So antipsychotic drug haloperidol you have started. This medicine is dopamine pathway inhibitor. So haloperidol is an antipsychotic medicine. This medicine is dopamine pathway inhibitor. This medicine is dopamine pathway inhibitor and can result in extrapyramidal symptoms. Can result in extrapyramidal symptoms. So this question is based on extrapyramidal symptom. This topic is very, very important for your exam, the extrapyramidal symptoms. So I will write the names of all extrapyramidal symptoms. You have to tell me the time of appearance. You have to tell me the time of appearance, as well as you have to tell me the best management, and if possible tell me the presentation, how this side effects are presented. So first is acute muscle dystonia. The first side effect is acute muscle dystonia. The second is Parkinson's. Second is Parkinson's. Third is akathisia. The fourth is tardive dyskinesia. The fourth is tardive dyskinesia. The fifth is neuroleptic malignant syndrome. Okay, just leave this NMS. Just answer me these four. What is the time of appearance? What is the time of appearance of extrapyramidal symptoms? So the first will appear after 4 days. So the mnemonic of 4. Second will appear after 4 weeks. Third will appear after 4 months. And this will appear after 4 years. So days, weeks, months and years. And these two are best managed by benzhexol. These two are best managed by benzhexol. If benzhexol is not given in MCQ, you can also give promethazine. You can also give promethazine. Akathisia is best managed by propranolol. It's a restlessness akathisia. And tardive dyskinesia, first of all, you will stabilize the patient by giving a medicine which are like velabenazine or tetrabenazine. So medicines are like velabenazine or tetrabenazine which you can give. So you can give medicines like velabenazine or tetrabenazine. And once patient gets stabilized, you will put patient on clozapine. You will put patient on clozapine. Right? So these are the things which we have discussed already during our discussion in lectures. So please remember, in antipsychotics, if we talk about antipsychotic medicines, side effects are very, very important. So side effects of antipsychotic drugs is a very, very important topic for your exam. Right? Next is, okay, one thing please remember, there are some antipsychotic drugs which are given in the form of depot injections. There are some antipsychotic medicines which are given in a depot injections like haloperidol, olanzapine, flufenazine. So flufenazine, olanzapine, haloperidol. So there are some antipsychotic drugs which are given in depot injection, they will ask you how these depot injections are given. How these depot injections are given? So answer is with the help of Z-track technique. So the technique by which these injections are given, the technique by which these injections are given to a patient, the depot injection, we call it Z-track technique. So antipsychotic drugs are given with the help of Z-track technique. Question number 16. So question number 16, a 32-year-old female suffering from stress incontinence since 3 years after her first delivery. So 3 years back she had to undergo some surgery, and after that she is now suffering from stress incontinence because during the time of delivery there is a possibility that her sphincter is ruptured. Now because of this problem, because she is a young female, 32-year-old female, she remains depressed. So she has a symptoms of depression because of this problem. Now you have to start a medicine that will take care of her both problems. So that will take care of depression symptoms as well as take care of stress incontinence. So please remember, drug of choice for stress incontinence. Drug of choice for stress incontinence is duloxetine. So duloxetine is a name of an antidepressant medicine. This medicine is SNRI. This medicine is an SNRI. So this is a best answer to be started over here. Although overall best medicines for depression is SSRIs. So in this question SSRIs are also given. But if you consider the whole clinical scenario, apart from depression, this patient is also having one more problem of stress incontinence, and drug of choice for stress incontinence is duloxetine. So in this case the best answer is duloxetine. Right? So which medicines are SNRI? Just remember the names of medicines which are SNRIs. So the drugs which are SNRIs, the medicines names are duloxetine, one more is milnacipran, and one more is venlafaxine. So venlafaxine, milnacipran, duloxetine are the medicines which are SNRI. Medicines which are SSRIs, these medicines are fluoxetine, one more is paroxetine. So do not get confused in two. If you look at here, these medicines also have the word zitine. So duloxetine also has zitine. So fluoxetine, paroxetine, fluvoxamine, all these are examples of SSRIs. Citalopram is one more example. One more is sertraline. Sertraline is one more SSRIs. And SSRIs are overall drug of choice for depression and anxiety disorders. Drug of choice for depression and anxiety disorder is SSRIs. But the names of SNRIs, because this is a new group of antidepressants which we people are using very commonly in India, so this can be asked. Right? So names of SNRIs, please remember. Right? Some students make a mnemonic of when dil mile. So when dil mile, so when is for venlafaxine, dil is for duloxetine, and mile is for milnacipran. Right? So these are the SNRIs. So in topic of antidepressant, I suggest you to read the classification of antidepressants carefully. Next question is regarding drug de-addiction. So if we talk about drug de-addiction, what is the answer of this question? Okay, Dr. Ritz. So Dr. Ritz, SSRIs are drug of choice for depression and anxiety disorders. Anxiety disorders can be of 6 types, which can be phobia, can be OCD, right? Can be panic disorders. So for all these anxiety disorders, SSRIs are the best medicines to be used. If you have any problem in psychiatry drugs, just let me know. Accordingly, we will discuss. So question number 17. Alcohol addict patient comes to you for in de-addiction clinic with his family members. So family members means the family support is there. So family support is there and patient is very much determined that he has to give up the habit of alcohol intake. So which medicine has no role in the de-addiction treatment plan? So the answer is disulfiram. So disulfiram is a drug that is given to prevent the relapse. So this medicine has no role in de-addiction. So this medicine is only given to prevent relapse. Right? So answer is B, Bombay. So most of you given the correct answer. So naltrexone is overall drug of choice for de-addiction. So overall drug of choice for de-addiction is naltrexone. Right? Sorry, please make a correction. Okay, in this question, the best answer is, please make a correction. No, the answer is correct. It's disulfiram only. Right? It's disulfiram only. Okay, let's discuss the drugs for de-addiction. So one is alcohol, one is opioid, and the third is nicotine. So which medicines can be given for number one, de-addiction or treatment of cravings? So medicine which is given for de-addiction and treatment of cravings. For alcohol, it is naltrexone. So for alcohol, it is naltrexone, which is drug of choice. But we can also use a medicine, the name is acamprosate. For opioid, this is methadone. This can be methadone or this can be buprenorphine. So both medicines are equally effective. Buprenorphine or methadone. And for nicotine, please remember nicotine skin patch. Nicotine skin patch. So nicotine skin patch is a treatment of choice, but we can also use medicine like vernicillin. We can also use medicine like vernicillin, and we can also use an antidepressant drug, bupropion. This is for de-addiction and cravings. Second question, they can ask you, what is a drug of choice for withdrawal? So what is a drug of choice for withdrawal? So alcohol withdrawal, the best medicine is chlordiazepoxide. Chlordiazepoxide. For opioid withdrawal, the same answer as above. Right? There is no nicotine withdrawal. There is no nicotine withdrawal. Third is, they can ask you which medicine is given for prevention of relapse, so that patient will not start taking the medicine again. So for prevention of relapse, please remember naltrexone. Naltrexone is again drug of choice, but we can also use a medicine disulfiram. We can also use a medicine disulfiram. Now for prevention of opioids. So opioid relapse, the best medicine is again naltrexone. The best medicine is again naltrexone. There is no nicotine relapse prevention. The last is toxicity. So if the question is come on toxicity, so there is no antidote for alcohol toxicity. We give the symptomatic treatment. For opioid, we give naloxone. And for nicotine, there is no drug. Right? So this is the table which is important for you. This question is actually partially correct. So do not concentrate on this question, because when I framed this question, there was something else going in my mind. So for timing, just leave the question, just concentrate on this table. This table is important for your exam. So one MCQ is confirmed from this table. They'll definitely going to ask you the drugs which are given for drug de-addiction. So just remember this table. This is important. Right? And there are some variations also which we have discussed during our lecture. Next is question number 18. Question number 18. Amoxicillin is a beta-lactam antibiotic. Amoxicillin is a beta-lactam antibiotic which is a cell wall inhibitor. This medicine is cell wall inhibitor and has a wide spectrum of action. Has a wide spectrum of action against many bacteria. but not against one bacteria out of these four. Can you find out against which bacteria this medicine is not useful? Against which bacteria this medicine is not useful? The hint is given already in question. It's a beta-lactam antibiotic. It's an inhibitor of cell wall synthesis. It's a cell wall inhibitor. And this medicine has wide spectrum of action. So can be given against all bacteria, but not against mycoplasma, because in mycoplasma there is no cell wall present. So in mycoplasma, cell wall is not present. So this is a bacteria which is devoid. This is which is devoid of cell wall. And because it is devoid of cell wall, there is no rationale of giving beta-lactam antibiotic. So beta-lactam antibiotics cannot be used against a bacteria which has no cell wall. So in this question, you have to remember classification of antibiotics. So one MCQ is confirmed from classification of antibiotics. So classification of antibiotic is based on mechanism of action. So classification of antibiotic is based on mechanism of action of antibiotics. So regarding this question, please remember this classification or the mechanism of action of antibiotics. This is very important topic, and we have discussed in detail this classification of antibiotics. So one MCQ is confirmed from this. So let's move on to question number 19. So question number 19 is based on the treatment of syphilis. Question number 19 is based on the treatment of syphilis. So patient has come to in skin OPD with a painless sore. So painless ulcer or sore, or we can call it chancre, is present. The picture is missing over here, so it does not matter. The history is sufficient. So painless sore is present over penis. There is no other significant symptom, but patient has given the history of unprotected intercourse with a sexual worker around 2 months back. Now, which treatment is the best treatment? So this question is based on syphilis. So patient has got syphilis. So we talk about syphilis. The first stage of syphilis is known as primary syphilis. So in primary syphilis, patient has only the single chancre either on the penis, genitals, or in the buccal cavity. Right? This is a primary syphilis. So patient is stable. So patient is stable in this case. Right? Second is known as secondary syphilis. Now secondary syphilis can be early latent or can be late latent. Then we have the tertiary syphilis. In tertiary syphilis, we have benign tertiary, we have cardiac tertiary, and we have neurosyphilis. We have the last one, the neurosyphilis. Right? So please remember, for the primary syphilis and for the early latent syphilis. For primary syphilis or the early latent syphilis, we will give 2.4 million units. 2.4 million units benzathine penicillin G. So benzathine penicillin G is a form of penicillin G which is always preferred if the patient is stable. So if the patient is stable, we always give benzathine penicillin G, 2.4 million units single dose. So single dose of 2.4 million units of benzathine penicillin G is given. Now for late latent, benign and the cardiac syphilis, you have to give 2.4 million units. So 2.4 million units of benzathine penicillin G once in a week, once weekly for 3 weeks. You have to give 2.4 million units benzathine penicillin G once weekly for 3 weeks. But for neurosyphilis, you have to give the other form of penicillin G. So you have to give aqueous penicillin G. So you have to give 24 million units. 24 million units of aqueous penicillin G. So whenever there is an acute emergency or patient is suffering from serious disease, we prefer to use aqueous form of penicillin G. So 24 million units of aqueous penicillin G is given for 14 days. So this question is based on treatment of syphilis, primary, secondary and tertiary syphilis. So this is important because syphilis is a landmark. Syphilis treatment is a landmark discovery in the history. So this question is important for your exam. Next is question number 20. A patient is suffering from MDR TB and has started a drug regimen but develops neuropsychiatric side effect. So patient has developed neuropsychiatric side effect due to the drug use. Now which of the drug is responsible for this? So this question is based on side effect of TB drugs. This question is based on side effects of TB drugs. So please remember ethionamide. Ethionamide is a TB drug that will cause hypothyroidism as a side effect. PAS is a drug which can cause SLE. So SLE is a side effect of PAS. Hypothyroidism is a side effect of ethionamide. Cycloserine is the one that can cause neuropsychiatric side effect. So this will cause CNS side effects. So C is for C. And rifampicin, you people already know, this medicine can cause hepatotoxicity, can also cause red discoloration of urine and body secretions. So red discoloration of body secretions in urine, and can also reduce the platelet count. So this question is based on side effects of TB. So we have discussed this side effects of TB drugs in detail already. So read this topic in detail, right? So medicine can cause hepatotoxicity, red urine, red secretions, and reduce the platelet count. So in this case, the best answer is cycloserine. So cycloserine is a drug which can cause CNS side effects. Question number 21. So question number 21. Patient is suffering from mucormycosis after COVID-19 infection, where the patient has taken the steroids. So patient was diabetic already and now developed mucormycosis because he has taken steroid during this COVID-19. Now you have started liposomal amphotericin B, which is a drug of choice for this condition. So which side effect cannot be associated with amphotericin B? So the answer is hepatotoxicity. So please remember, amphotericin B is an antifungal drug which can cause hypersensitivity reaction. Number 2, this medicine can damage the kidney and cause nephrotoxicity. And as a result of nephrotoxicity, this medicine can cause loss of potassium and magnesium, can result in loss of magnesium and potassium. And due to this loss of magnesium and potassium, this medicine can cause ototoxicity and neurotoxicity. So drug can cause ototoxicity, neurotoxicity, hypokalemia, hypomagnesemia, nephrotoxicity. So in antifungal drugs, amphotericin B is important for your exam. So please concentrate on amphotericin B drug. Next is question number 22. So if we talk about question number 22, this question is based on anti-HIV drugs. So all medicines are protease inhibitors given for the treatment of HIV except. So any medicine which is a protease inhibitor, so that medicine always end up with the word Navir. So if you find out in this case Abacavir. Abacavir is a drug which is not ending up with the word Navir. Rest of the medicines are ending up with the word Navir. So classification of HIV drugs. So classification of HIV drug is important for your exam. So read this classification of HIV drug which we have discussed in detail. Like during our discussion we discussed that there is a group of medicine NRTIs. NRTIs are the drugs, they end up with the word Vudine. So NRTIs end up with the word Vudine, but there is one different drug, Abacavir. Abacavir is a different drug. The second group is NNRTIs. So NNRTIs are the drugs which end up with the word Virin. So all these medicines have Virin in their last, but there is one different name. The drug is Nelfinavir. So Nelfinavir is a different name. Next is integrase inhibitors. Third group of medicine is integrase inhibitors. So integrase inhibitors are the drugs which always end up with Tegravir. Integrase inhibitors are the drugs which always end up with Tegravir. And the fourth is protease inhibitor. So protease inhibitors are the drugs which end up with the word Navir. So these are the four main groups of HIV drugs. Protease inhibitors has the word Navir. NRTIs has the word Vudine. NNRTIs has the word Virin. Integrase inhibitors has the word Tegravir. Some exceptions like Abacavir is also NRTI and Nelfinavir is also NNRTI. So question number 22, answer is B. One more thing which is important here is the side effect of Indinavir. So Indinavir is a drug which can cause renal stones. So one of the important side effect of indinavir is renal stone as a side effect. Let's move on to question number 23. So if we talk about question number 23, a female patient suffering from tuberculosis comes to you with oral contraceptive failure history. So female patient has come to you with oral contraceptive failure history and she is also suffering from TB. So whenever we give TB drugs, we generally give HRZDS for the treatment, right? And out of these medicines, if we use rifampicin, so rifampicin is a drug which is liver enzyme inducer. So rifampicin is a liver enzyme inducer and can induce the metabolism of OCPs. So liver enzyme inducers can induce the metabolism of OCP. So in this case, rifampicin is the one that is responsible for contraceptive failure. So regarding this question number 23, which I have taken from General Pharma, so you should be knowing the names of liver enzyme inducers and inhibitors. So you should be knowing the names of liver enzyme inducers and inhibitors. So please remember the names of liver enzyme inducers. We discussed some mnemonics during our lecture. So liver enzyme inducers are car gas and liver enzyme inhibitors are peacock is very pretty. So please read these names by yourself because we have discussed so many times during our lecture. Question number 24. So question number 24 is based on clinical trials. So the second most important topic in General Pharma is clinical trials. So safety studies. So safety studies and toxicity studies are covered in phase 1. So phase 1 of clinical trial is known as safety study or toxicity studies. So safety studies and toxicity studies are phase 1 of clinical trial, right? So answer is phase 1. So read about these clinical trials also. So clinical trials we have covered in a short during our lecture, but this topic is covered extensively in your PSM class. So read this about this clinical trials different phase, right? The last question, question number 25 is from anti-cancer drugs. So question is, all these medicines can cause pulmonary fibrosis except. So vincristine is the answer. So vincristine will not cause pulmonary fibrosis. So we discussed during our lecture the medicines which can cause pulmonary fibrosis are, if you remember, carmustine. So the medicine has the mnemonic like car, truck. So in truck, please remember methotrexate. Next is bus, busulfan. So this is car, this is truck, this is bus, and they will blow the horn. So all these vehicles will blow the horn. We call it bleomycin. And amiodarone is an antiplatelet drug that will also cause pulmonary fibrosis. So regarding anti-cancer drugs, side effects are important. So side effects of anti-cancer drugs you should read. We have discussed 20 or 25 points in our lecture. So read those points. All MCQs will be solved definitely during the exam. So these are the 25 most important topics which can be asked probably this year in your exam. Now apart from these 25 topics, there are 17 more topics. There are 17 more topics which I wanted to cover, which I wanted to include in these questions, but I couldn't because I had a limitation of this 25 only. So I've just written these topics for you people. So I suggest you that you read these topics by yourself. So OP poisoning was asked last year. There is a topic of alpha blockers. So in alpha blockers this year, tamsulosin. So please concentrate on tamsulosin. So there's a high possibility that tamsulosin or prazosin question can be asked. So tamsulosin, prazosin question can be asked. So beta 2 agonist side effect we have discussed in between. Indications of thiazides. So we talk about thiazide diuretic. There are two important indications. One is hypocalcemia and second is this medicine is given for diabetes insipidus. So hypocalcemia, diabetes insipidus are two important indications. So this can be asked. Now very interesting fact. Last year in your exam they have asked about tadalafil. So tadalafil is a drug which is given for pulmonary artery hypertension. The topic is pulmonary artery hypertension. So they asked which medicine is given for pulmonary artery hypertension and has a long-acting drug. So tadalafil is a long-acting medicine given for pulmonary artery hypertension. But this year they can ask you about bosentan. So please be careful. Bosentan is a drug which is an endothelin antagonist. So ENT stands for endothelin. So it's an endothelin antagonist. So this medicine can be asked this year because last year they have asked about tadalafil. First time they have touched this topic of pulmonary artery hypertension, right? First time they have touched this topic of pulmonary artery hypertension in FMG exam. So endothelin receptor antagonist can be asked this year in 2022. Now digoxin toxicity risk factors we have covered in between. Misoprostol will cause Mobius syndrome we have covered. So tocolytic topic is also important in OBS gynae. So please cover from there, right? And types of insulins. So types of insulins they can ask. Drug of choice for prolactinoma. Drug of choice for prolactinoma like cabergoline they can ask. The antidote of benzodiazepine. Antidote of benzodiazepine flumazenil. So flumazenil is an important drug for you for your exam. Lithium is a mood stabilizer which they can ask. So lithium, read lithium from your notes if possible. So treatment of malaria is already covered in your PSM. So malaria treatment they can ask. Medicines which are given for MRSA. So this we have covered during our lecture. There is a mnemonic. MRSA very difficult to lyse. MRSA very difficult to lyse. Right? So MRSA drugs are important. Next is treatment of pseudomembranous colitis. So treatment of pseudomembranous colitis, we know that drug of choice is oral vancomycin. Drug of choice is oral vancomycin. The second drug of choice is IV metronidazole. So this is important. And in autocoids, if possible, if time will permit, read the difference between generation 1 and generation 2 antihistaminic drugs. Generation 1, generation 2 antihistaminic drugs, and the last is in general pharma, read about DRC. So read about dose response curve. So these are approximately 42 topics, 25 MCQs and 17 more topics. So read first 25 questions with their topics which we have discussed plus 17 of these, total 42 topics. If you read only these 42, the high possibility that you are able to solve at least 60% of your MCQs, right? So all the best for your exam. Keep on working hard. My wishes are with you, right? You will definitely come up with flying colors in pharmacology. And if anytime you have any query regarding this pharmacology, you can directly message me on this number. So WhatsApp me on this number, right? So if you have any query, we can solve immediately there and then only. So all the best for your exam. Take care.